Hello, and welcome to this series of talks on nuclear medicine thyroid scintigraphy. Now in the first talk today we're going to have an introduction to the various isotopes that we use to image the thyroid gland and thyroid disease, and we'll also discuss benign conditions affecting the thyroid gland where we use scintigraphy to image them. So any discussion of scintigraphy in the thyroid gland needs to begin with iodine and a discussion of its various isotopes. Now why is this? Well, as we know in nuclear medicine, we usually have to combine an isotope with a pharmaceutical in order to obtain a radiopharmaceutical which will go to the desired location. So for example, if we wish to perform a bone scan, we need to link technetium, an isotope, with methylene diphosphonate, which will go to the bone. If we want to do a renal scan, we need to link technetium, the isotope, with Mag3 to take it to the kidney. But fortunately, the thyroid gland will naturally concentrate iodine, and therefore it will, without any pharmaceutical, take up the various iodine isotopes. Now there are 37 iodine isotopes in nature, but only 4 of them are used in medical practice. The one which is historically used most frequently is iodine 131. That's relatively cheap and is produced in nuclear reactors as a fission byproduct. It's the isotope of concern in nuclear accidents. It does have a long half-life of 8 days, and you might wish to note that if you give the patient a therapy dose and they take an airplane soon afterwards, because there's a possibility that they may activate radiological alarms in airports. It also produces a beta particle, which is how it can be used for therapy. In addition to the beta particle, it does produce a gamma ray which we can use in imaging, mostly a 364 keV gamma ray, and that's quite a high energy photon, so if you're going to perform imaging, you really will need a high energy collimator, that is a dedicated high energy collimator, in order to get optimum imaging. Iodine 123 is somewhat more expensive, but in relative terms, considering we're not linking it to an expensive pharmaceutical, it's actually relatively cheap compared with some other tracers. It has a short half-life of 12.6 hours, and that's obviously much more favourable than iodine 131 because the patient will receive overall a lower dose. It has a low energy gamma emission, 159 keV, which is very similar to the commonest isotope we're using, technetium, and therefore we can use the standard collimator. These are the 2 isotopes of iodine we'll be using in our practice usually. Some people have used iodine 124 for positron emission tomography imaging because it is a positron emitter with a half-life of 4 days. However, it's not widely used in clinical practice. Iodine 125 is not used in thyroid imaging, but I'm just mentioning it for completeness. It's used in brachytherapy seeds for prostate therapy, for example. So what non-iodine isotopes do we use when we're imaging the thyroid gland? Well, our commonly used isotope in the department, which we will have readily available, technetium, can be used, technetium 99M, which of course has an energy emission of 140 keV and a short half-life of 6 hours. Now, we don't have to link technetium with a pharmaceutical to get it to be taken up by the thyroid gland. Like iodine, it is naturally taken up by the thyroid gland, although it is not organified. That's the difference. That has an advantage in that we can image with technetium very quickly after injection, 20 minutes, whereas we usually wait 3 to 4 hours after we administer an injection or an oral dose of iodine 123 before we would image the thyroid gland. So the form in which the technetium will be administered is technetium pertechnetate. That is the free or unbound form of technetium, which we will elute or draw off from the generator. That's what comes out of the molybdenum generator, which we will have in our radiopharmacy, which the vast majority of nuclear medicine departments will have. So if we want to do a thyroid scan, it's a readily available cheap tracer we can use any day. Whereas most departments, if they want to use iodine, they'll have to order it in. Just going to mention F18, which is of course the most commonly used positron emitter in nuclear medicine practice, with a half-life of 110 minutes. It's widely used in cancer imaging. It's not used in differentiated thyroid cancer, that's the commonest type of cancer, of thyroid cancer, which we'll be discussing later, but it's occasionally used to image the more malignant variants for medullary carcinoma of the thyroid and in anaplastic thyroid cancer. One thing I just do want to mention about F18 and fluorodeoxyglucose, which is the commonest radiopharmaceutical we administer, as I said, in PET scans, we can sometimes incidentally see diffuse uptake in the thyroid gland on, for example, an FDG PET scan being performed for cervical cancer or lung cancer. What's the significance of that, you might be asked, and what's the significance of incidental focal uptake? Well, just to note it here, because it's as good a place as any, as a general rule, there should be only very, very low-grade uptake in the thyroid gland in an FDG PET scan. If you see diffuse increased uptake, that may be due to thyroiditis or possibly due to Graves' disease, so that's something that you may certainly wish to mention in your report. If you see a focal uptake of focal area of moderate or intense uptake, a noticeable area of focal uptake within the thyroid gland incidentally on an FDG PET scan, then we certainly might want to think that there's a thyroid cancer there. It might turn out to be a hyperplastic nodule or adenoma, but as just a rough rule of thumb, 1 in 3 of those turn out to be cancers. Now, they may not be very significant cancers, and the patient's other condition that they're being scanned for may supersede that, but we certainly do want to mention that and mention that it might well be a thyroid cancer, and the clinician can take the appropriate action depending on the clinical circumstances. Clearly, if the patient has widespread metastatic disease from a lung cancer, it may not be appropriate to image it. I'm just going to also mention that that's only for fluorodeoxyglucose. The amino acid tracers like choline, F18 choline, they are taken up in organs which are producing quite a bit of protein, and so you'll normally get diffuse uptake in the thyroid gland. So just very quickly to summarize, incidental uptake on PET scans in the thyroid gland, FDG PET scans, diffuse uptake, think thyroiditis or Graves' disease, FDG PET scans, focal uptake, 1 in 3 possibility of being a cancer, choline PET scans or other amino acid tracers, that's perfectly normal and we don't even need to comment on that. So, what is the purpose of thyroid scintigraphy in benign disease? Well, considerably less than it was in the past. In the 1960s, there used to be very many thyroid scintigrams being performed to look for cold nodules, that is, focal areas of lack of uptake, because tumours and carcinomas were often seen as cold nodules. However, as soon as ultrasound and fine needle aspiration became evident in widespread clinical practice, the number of thyroid scintigrams being performed for this purpose dropped drastically, because it wasn't a particularly accurate way of finding cancers, and fine needle aspiration together with ultrasound is much more accurate and is the current gold standard. However, there are still many circumstances in which we will use thyroid scintigraphy. So the first one is to determine if a thyroid nodule is toxic when we see a patient who's got background hyperthyroidism. What is a toxic nodule? A toxic nodule is a thyroid nodule which is causing hyperthyroidism. So we may be sent a patient who is hyperthyroid. An ultrasound scan has revealed a nodule. The question is this nodule causing the patient to be hyperthyroid? Or is it an incidental nodule and the patient is hyperthyroid due to them having Graves' disease. Why would that be of significance? If we can identify a single toxic nodule, the patient could have a hemithyroidectomy. If the patient has Graves' disease, the patient will require a total thyroidectomy. And clearly it's desirable only to have a hemithyroidectomy if possible, both because you are going to have less operative risk, you're not going to have the risk of damage to both recurrent laryngeal nerves, and also, of course, you'll still have some thyroid gland left at the end of the procedure, at least half a gland, and even though you might require some thyroid supplementation, you'll still have a bit of thyroxine being produced, so you'll never go completely hypothyroid. And of course, one of the problems about having a total thyroidectomy is you're completely dependent on having thyroxine for the rest of your life. So it's nice to have at least some thyroid gland present. So that is one of the main uses, that is probably the most common use for thyroid scintigraphy, certainly in our clinical practice. You can also use thyroid scintigraphy to distinguish thyroiditis from Graves' disease. In thyroiditis, the patient may be hyperthyroid, but when you give them the radioactive tracer, not a striking amount will be taken up by the thyroid gland. It'll either be normal or low. Whereas a patient with Graves' disease is hungry to take up as much iodine as possible or technetium into their thyroid gland and will concentrate that. We can quantify that by measuring the patient's radioactive iodine uptake, but we have to use iodine tracer to do that. The third reason why we might wish to perform thyroid scintigraphy for benign disease these days is if we want to identify ectopic thyroid tissue. As you know, the thyroid begins at the base of the tongue, and during the development of the fetus, it descends from the posterior aspect of the tongue down the midline to its final resting place in the middle of the neck. And there can be remnants of thyroid tissue left behind anywhere along this line, and occasionally a clinician will ask you to perform a scintigram to identify these. So, as I mentioned, we can use iodine or technetium pertechnetate, that's the free form of technetium which comes out of the generator, to demonstrate the size and shape of gland and get a rough idea of activity. But if we want to do quantification studies, accurate quantification studies, we need to use iodine. And as I mentioned before, malignant tumours tend to present as cold nodules in the thyroid gland. It's only really case report stuff where hyperfunctioning cancers of the thyroid gland have been described. It's very rare. Now, sometimes people say to me, well, this is very strange. Why is it that thyroid cancers are cold on a thyroid scintigram, but then we also do whole body iodine scans in order to identify metastases from thyroid cancer? Well, everything in nuclear medicine is relative. So we will have in a patient who has an intact thyroid gland, the normal thyroid tissue will have 10 times the avidity of iodine for iodine compared with the tumour. Therefore, the tumour will look cold compared with adjacent normal thyroid tissue. However, once you've performed a total thyroidectomy, then the tumour will take up more tracer than adjacent non-thyroid structures such as lung tissue or bone tissue, and when we scan the patient then we will see the tracer uptake of iodine as high compared with the adjacent structures which have no avidity for iodine. So I hope that's clear. Okay, so let's get on and show some pictures now. So this is a relatively normal scintigram of the neck and showing the thyroid gland, a technetium 99M scan, and just have a few things outlined here. So these are the upper and lower poles of the thyroid gland, the right lobe, the left lobe, the isthmus here. Normal bow tie appearance. We can perform oblique views with the patient's head turned to their left and the right, if we wish. There's some uptake in the salivary glands. These are the submandibular glands and the parotid glands. This focal area of uptake here is a piece of lingual thyroid, just to show you where it's located, and we might see thyroid tissue anywhere, as I said, along the embryological line of descent here. So a patient might have a thyroglossal duct cyst, perhaps in the midline and the neck. It's rare for the clinicians to ask for imaging, but just occasionally they will. Okay, let's just look at a couple of cases. So as I mentioned, scintigraphy is now ultrasound is now the first line investigation we perform for almost any thyroid condition. So when you're interpreting nuclear medicine studies, you really should have some familiarity with this. Here's our trachea, here's our right lobe, nicely labelled, carotid artery. I'm not sure if that's the jugular vein there. I think that's a bit of sternomastoid muscle. And here's the isthmus of the thyroid gland. This is the normal thyroid gland here, and we have a uniform high echogenicity nodule in the right lobe. So, in this case, the patient was hyperthyroid, and the clinician wanted to know if they had Graves' disease and did they need to do a total thyroidectomy, or was this a toxic nodule. So here's our thyroid scintigram. If I just go back to the one I showed you a minute ago, it's going to get rid of this here, and here's our normal bow tie shaped thyroid gland. And here we are again. Here's our anterior neck view, a spot view of the neck. And clearly this is not the same as we saw a minute ago. We're completely missing a left bow tie. And this one here is very fat and intense. So that looks like there's quite a lot of tracer there. You'll sometimes see this SSN marker and a little arrow, and sometimes there'll be a little round thing here. This is suprasternal notch marker. It's just some anatomical localizer the technologists have put on for you. Here's a spot view of the chest. Just note activity in the stomach. One of the places that technetium pertechnetate, the free form of pertechnetate, goes is the stomach. We've done oblique views here, but they haven't added very much. So this patient has, maybe there's a tiny bit of activity there, but I think that's just background, because when we look at our spot view, we can't really see anything here at all. So this left lobe, which was normal on ultrasound, is completely suppressed. And therefore this is a dominant toxic nodule, and hopefully this patient should get away with the hemithyroidectomy. Here's another patient. Left lobe of the thyroid gland, large nodule, trachea. It's going into the isthmus region. This is muscle here, strap muscles. That's probably our carotid artery there. Normal looking right lobe, sternomastoid muscle, strap muscles. If we're looking for parathyroid adenomas, which we'll talk about later on, they'll be back here somewhere. Here's our carotid artery, and I think that will be our jugular vein there. So this patient, intense activity in the left lobe, but really hardly anything to see here on the right side. So again, a toxic nodule on the left corresponding to this toxic nodule here, corresponding to the intense activity. This proves it's a toxic nodule, and therefore hopefully the patient will be suitable for a hemithyroidectomy. Next patient, right side, an irregular solid and cystic nodule in the right lobe, I think. Here, I think this is our left lobe here, a couple of smaller nodules. So this is a multinodular goiter. Same question from the clinician. Here's our scan, and we've got uptake on the right, and clearly that nodule we saw on the right is quite large. It's taking up more tracer than the left, but it's not the left side is not suppressed. So we wouldn't be able to tell the clinician that this was a dominant toxic nodule here, even though it is quite large. Again, here's our stomach. Normal site of technetium pertechnetate uptake. Okay, so I think we'll leave that talk there, and in part 2 we'll discuss the nuclear medicine techniques that we use to image thyroid cancer. Thank you.